Hey Refam, my name's Kate and welcome back to My Surgeon Says, a podcast with real surgeons, real experience and real advice. Today we're chatting about reconstructive versus cosmetic plastic surgery. When I thought about this topic, I didn't really think we'd spend so much time on reconstructive surgery, but I am so happy we did. Richard and Kim explain some wild operations that surgeons are performing to either repair or rebuild parts of the body that have been damaged by illnesses like cancer, congenital disease, or through accidents. Keep listening to hear why ignoring a non-malignant skin cancer on your nose may lead to forehead surgery, how the human brain will automatically start to use your index finger as a thumb, and why breaking your jaw might actually lead to a better facelift. As always, please rate and review us wherever you're listening. It really does help people know that we exist. So plastics can be largely broken down into two camps, reconstructive and cosmetic. Could you explain the differences between those two larger specialties, and then we'll get more into the nitty-gritty?
The difference is much greyer than what it maybe seems from the outset. So the reconstructive work that we all did when we were going through training certainly has a cosmetic element to it. And then a lot of those skills that we picked up in reconstructive work are then applied in the cosmetic work we do. And there's lots of examples of that. Breast reconstruction into breast reduction, facial palsy work overlaps with facelift work. I suppose the fundamental difference really is maybe around the urgency of the surgery. So with cosmetic surgery, there's a more of an elective component to it. You can also look at it through the lens of what is the aim of any surgery, in the sense to improve the quality of life. Whether it's reconstructive or cosmetic, that's always the aim of any surgery. The things that make them different are fewer than the things that sort of join them. It's much more common that people either focus on purely aesthetic work or focus purely on reconstructive work.
And then within that, there are obviously a bunch of subspecialties. So I just wanted to go through some of them today, and then after we delve into what they are, talk about how important you guys actually think being hyper niche or super specified is. I'd actually like to start with reconstructive, and I know that's not what we do here, but both of you have experience with post-mastectomy breast reconstructions. We've talked about that in depth on another podcast. I'll link in our show notes. But could you guys just a quick summary of what that entails, because I do think it's really interesting.
So that in isolation is usually for women that have had a recent diagnosis of breast cancer, and then what we'd be talking to them about then would be an immediate breast reconstruction. So they would have the breast treated for their cancer at the same time that they're then having a reconstruction, and the sort of reconstruction options are really implant-based or their own tissue-based. We used to do a lot more of the combination of the two, but my understanding is that implants are usually just used more so in isolation now, or your own tissue, which is generally abdominal tissue. And then there's delayed reconstruction, which is, say, for a woman's had their breast removed 1, 5, 10, 20 years ago for cancer, and then they're coming in to talk about having that reconstructed. So that's a delayed reconstruction. And that's where Richard was just talking about. That's more on the elective side of things. It's to make that woman complete again, but it really is more of an aesthetic type of procedure at that point, because they've had their cancer treated, so there's no urgency. And those are probably women that are actually sitting on, a lot of them on waiting lists at public hospitals, because their cancer's been treated, you're fine. You can just wait to have that done wherever down the track. And then the third group is patients that have high-risk breasts, so family history of breast cancer, and they've either been gene tested or they've elected to have both their breasts usually removed if they haven't already had cancer or cancer treatment. So again, it's elective surgery, it's planned, but often it's a little bit time critical as well, because they obviously don't want to wait 10, 15 years, because they have a greater chance of developing breast cancer at that point. But there is time to be planning and making decisions of what type of reconstruction that they would want to have done.
For tissue only, is there the risk that then that tissue that's placed in could also become cancerous, especially for that latter group? impacted at all? They're already high risk.
The tissue that's coming in is not breast tissue, so that has zero chance of developing breast cancer. Plastic surgeons don't do the mastectomy, it's generally breast surgeons. But part of a mastectomy is to try and remove as much of the breast tissue as possible. So that means going very close to the skin and right on the muscle. In theory, you could leave a small amount of breast tissue there, and that tissue could still be vulnerable to breast cancer. The other thing that sort of evolved quite a while ago is what's called a nipple-sparing mastectomy, where previously the mastectomies used to be much more aggressive, including muscle, the nipple, so far more radical. Now it's evolved, particularly with these prophylactic procedures, where they actually preserve the nipple. Now, there is some small risk in doing that because that has some breast tissue as well, but it's really a risk reduction procedure. And obviously if you're doing even a nipple sparing, you're removing most of that tissue and so significantly reducing the risk. There's even some papers and even doing a breast reduction where clearly we're not removing all of the breast tissue, somewhat decreases a woman's chance of developing breast cancer because we're actually reducing the amount of breast tissue that's there. So I wouldn't be recommending having a breast reduction to prevent breast cancer.
Like you mentioned, breast reconstruction is almost always to do with breast cancer. What about craniofacial? Because that's also reconstructive, but are other factors coming into that?
Did you do a fellowship in craniofacial?
I did.
No.
Not that I'm aware of.
No, spread that rumour.
A lot of craniofacial work, there's some overlap with maxillofacial work as well. So that's all in that head and neck region. And a lot of that is paediatric based. So children that are born, there's lots and lots of fancy names, but for lots of different syndromes. But funny shaped heads is probably the easiest way to put that all in a box. And so like eyes too wide apart, eyes too close together, and skull bones that are unusually shaped. And that some of those things can cause issues with vision or with brain development. And so they have pretty major surgeries, often as not as babies, but as 1+, basically peel off the skin of the head and take all the bones off and reshape them all and put them all back on again. It's unbelievably powerful and clever. And the breast surgery we talked about is combined with a breast oncology surgeon, whereas these procedures are often combined with a neurosurgeon. So they're the ones that deal with getting the bones off and making sure that the brain part of it is all fine. And then there's other procedures where, say, the jaw, upper or lower jaws are not normally developed, so either overgrown or undergrown, and they can actually then do surgical procedures to break both the jaws and either put one back or put one forward and realign those. And then that's often done with dental experts as well. So they're putting braces on the teeth and then lining up the teeth so that it all works as well. And a degree of that is reconstructive, but also a lot of it is more aesthetic as well, because if you can't bite your teeth together, then it's pretty difficult to eat. But the appearance is quite significantly changed with those procedures as well.
The maxillofacial procedures are incredibly powerful, and it would be something that I'd assess you for if I'm discussing a facelift, because sometimes if you've got an under-projecting jaw, that can impact the neck angles and can contribute to not great definition of the neck. So sometimes we will combine those sorts of procedures with maxillofacial procedures.
Is maxillofacialist just the Australian craniofacialist?
No,
or they're different?
No,
different.
so Cranio is the skull part of it,
Right.
whereas maxillofacial is more the mid-face and jaw part of it. But there are some...
So many surgeons.
There's some people overlap, but there's some that are quite separate.
Yeah, okay.
And a lot of maxillofacial surgeons are actually fully dual trained, and they have full dentistry degree and a full medical degree and then do surgical training. So part of the maxillofacial sort of surgery area that plastic surgeons generally deal with themselves without any other specialists for cleft lip and or palate. So a cleft lip is where the baby's born and the lip doesn't join up, and it can be on one side or both sides. And then the same thing with the palate, so the roof of the mouth, and those can be combined or separate. So the lips could be normal, but they could also have a split of their palate at the back. So there's quite significant surgeries that need to be done. Again, very reconstructive, but also very aesthetic. So obviously having the lip margin lining up, the nose, because the split goes into the base of the nostril. So to recreate the shape of the nose. And I think like when we were kids that had their lips repaired, the noses probably never were at that time. So they often had really flat noses. And so there's a lot of emphasis now on getting the aesthetics right at that first procedure, but also it's a functional, because if a baby has a cleft lip or palate or both, they can't suck normally. And so there's special bottles that they can have so they can actually feed when they're newborn babies until those procedures. And a lot of aid work Australians and New Zealanders do to Pacific Islands and Southeast Asia. It's a very high prevalence of those conditions in those countries.
Interesting. I was just thinking when you were saying it, because I was like, you heard about cleft palates all the time growing up. Never saw anyone with one. But I'm like, I guess if they got...
Well, they would have had surgery before they were one. Yeah. But it's interesting, you were talking previously about the overlap between reconstructive surgery and aesthetic surgery. And cleft lip is a perfect example. And if you take it from the point of view of the cleft lips, to repair a cleft lip, you really need to understand the anatomy of the lip and what a normal lip would look like. And then when we turn to facial surgery, and one of the trends at the moment would be a lip lift surgery, the knowledge of understanding where the muscle is, how it attaches onto the nasal sill, that then plays into the more aesthetic side of surgery. So there's a huge amount of overlap and between the two, and the skills are transferable and the anatomy is exactly the same, or correct in the case of a cleft lip is restoring the anatomy to how it should be, and then in aesthetics is basically doing the same, just getting the aesthetics back to what it was at a more youthful stage. So,
Richard, you obviously did a lot of work with rhinoplasties. Did you as well?
Some,
yeah.
Yep.
What about that? Obviously can be cosmetic and reconstructive depending on what's happening, but also can you just talk about what the process is?
I did do cosmetic rhinoplasty, but I also did a lot of nasal reconstruction after skin cancers.
Did you get on the outside of the nose or the inside of the nose?
Sometimes the whole nose off and have to make a nose from scratch. I'll show you some photos.
Yeah,
oh my God.
Sometimes there are skin cancers and they're so aggressive or they've been left so long that it's usually what's called a basal cell carcinoma, that it's gone full thickness through the nose and sometimes a lot of the nose. I've certainly had cases where there was basically no nose left. And then what you do is a staged procedure where you turn down a bit of the forehead, keep it attached there, so you walk around with a bit of a trunk, and use that skin to make the nose and create a lining and maybe put some structure in there as well if the cartilage has to be sacrificed. And then come back at 2 weeks, divide the trunk. So you still end up with a scar in the forehead where that skin's come from. But it's actually this forehead skin is quite a good match for the nose. Then transferring those skills into a rhinoplasty, having that knowledge is helpful in that. But rhinoplasty also has gone through a big transformation in our careers. So when I was first starting in training, most rhinoplasties were done via a technique called a closed rhinoplasty, where you just made a small incision on the inside of the nose, basically degloved all of the nose, smashed off. And I'm using
peel
graphic.
It back, so you couldn't see really what you were
I'm
doing.
using graphic terms because they did do it pretty graphically. Basically get a big chisel, whack off the dorsum, the bridge of the bump, and then break the bones here and bring the nose in, do something magical with the cartilages and stitch it all up. And they generally used to do that in around 30 minutes. Like I remember doing cases as a trainee with senior plastic surgeons, and they would it would be well under an hour for that sort of procedure. And then I suppose pretty early in my career, everyone started doing what's called an open rhinoplasty, where you make a cut across the columella here and flip the nose back like you're lifting the hood on a car, and then you see all of the anatomy, and then you address each component of the anatomy almost independently, and then put the skin back down and stitch everything up. So basically went from a half-hour procedure to a 4-hour procedure. I haven't really done rhinoplasty for I'd say 10 years or maybe a bit less. But even then, when you needed extra cartilage, you would harvest a rib. And now virtually no one does that, and they get cadaver rib. So, yeah, it's all cadaver rib now.
There you go.
Dead rib. Love it.
Dead rib.
And also with those procedures, functional is the
Yeah.
function
So,
is
'cause if
really,
you stuff that up
really
and you can't
important.
breathe.
Closed procedure, it was pretty much standard. You couldn't breathe after.
But your nose looks smaller, so no.
Yeah,
Price to
nose
pay.
look better.
My friend said he got sleep apnea after he had a nose
Yeah,
job.
quite possible.
Yeah.
Can't breathe.
So my good friend Peter Callan, shout out to Pete, he'd done a case a couple of weeks ago, and she'd had a rhinoplasty a long time ago and couldn't breathe or smell for, I think, 20 years. And then he did what is now a standard rhinoplasty, modern rhinoplasty now, and then she woke up and could breathe and smell.
Do you smell again?
I think so.
Wow.
Did the reconstructive one, because that's this skin up there. So I guess like the nasal passages still exist in the skull, but so like the smell sense isn't impacted.
No, not generally.
So what about the little hairs that protect you? Do people get sick?
But there are other, Richard was talking about basal cell cancer, which is from the outside in, but there are other cancers that we've both done lots of reconstruction for that are like from the oral cavity or the nasal cavity, from the inside out. And so there's often head
From
and
like
neck
smoking?
commonly.
Most common.
So there'd be another specialist often involved then, called a head and neck surgeon. So they make a big hole, and wherever it is, if it's the tongue or the cheek, the palate that we were talking about before, or inside the nose, they take out the cancer, and then whatever the defect is,
What do you do with the tongue?
reconstruct
Does it just grow
it.
back?
No. So a common operation for that would be what's called a free flap. So that's where you take some tissue from another part of the
But
body.
it's not free.
It's not free at all. It's not, certainly for the people that are doing the surgery, it's like many sleepless nights. And
Where do you take it from?
so the forearm is a good area. So you take a patch of skin, so depending on how big the defect is, with its blood supply, so an artery and vein or a couple of veins, and then you do microsurgery into the neck, because they're often, if they've got cancer, tongue or in the mouth, they're having the neck glands removed at the same time, and so the other surgeons usually opened it all up, and there's lots of blood vessels there. So to do microsurgery to join that up, keep that piece of tissue alive, and then it becomes the new tongue or the lining of the cheek. If there's smaller areas, you can occasionally do a skin graft on its own, but often these patients have had radiotherapy, they're smokers, so they've got poor quality tissues. So
when they're just tasting stuff,
Operations.
there's just like a bit that's real smooth that doesn't, wow.
That's then another crossover. So the neck dissection, to remove all the lymph nodes from the neck, that usually was a plastic surgery procedure, but it gives you a very good understanding of all the anatomy. So where all the nerves are running, where all the muscles are, the platysma, which is part of a facelift, this crossover of understanding all of that anatomy and then applying it in a different operation. Same skills, just applied in a different way.
Well, we talked about craniofacial, but what about facial reanimation?
Yeah, I was actually just at a conference a couple of weeks ago, which was a facelift conference, but they also talked a lot about facial reanimation. So people would probably be familiar with a Bell's palsy, where your facial nerve stops working for a variety of reasons. And sometimes those deficits can be permanent, or it could be because you've had a tumour removed, or some people are born with facial nerve weakness, and so that side of their face is droopy. And so there's a whole lot of techniques and like some really amazing procedures can be done to try and reanimate, which means make the muscles work again. So for example, have a natural symmetric smile that looks normal. So the facial nerve is one of the cranial nerves. There are 12 cranial nerves. That one can be affected, but one of the other cranial nerves is not affected. And so you can actually cut that nerve and put it into the facial nerve. You need to retrain yourself, do a different action which will elicit a smile, but it can look quite natural.
The people's pictures were amazing. Like then they were smiling on both sides, and it was like completely symmetrical, and you would have no idea that in those before images there was like
Complete
massive,
palsy.
animation on one side and nothing on the other. For Cosmetic, we lump together breast, body, face, and by lump together I mean we do all of those surgeries. Is that a common pairing to put those ones together, or do you find people in cosmetic practices are doing like rhinoplasty and tummy and breast, or or do people get more niche than what we do?
I think there's some people that would be like super niche and just do only facial, so like only facelifts or facelift plus nose. And there's some people that are very specialised in doing nose, but they probably don't do 100% of their practice only nose. They'd still do maybe a smattering of a few other things. In terms of body, I don't know if there's anyone that's like tummy tuck specialist, because patients don't always know if that's what they need. And we both do a lot of lower body lifts, for example. There's definitely surgeons that don't do that, but they'll do abdominoplasty. So they either will not see patients that have had massive weight loss, or they'll see them and say, look, the right operation for you is a lower body lift. I don't do that. Go see these guys. Or the only thing they have to offer is a tummy tuck. So they'll say, you're perfect for a tummy tuck, and they'll have that, and they will not have a great outcome. So
then they come and see us.
Yeah, then they still come and see us, but they've already had a surgery. So I think like people that are specialising in breast tend to do breast and tummy.
I think it'd be unusual to do breast and not tummy just because there's such an overlap in the patients. So it'd be weird if someone came for a tummy tuck and also wanted a breast reduction and say, look, I'll do the tummy tuck, but you should go somewhere else for the breast reduction. So there's a lot of overlap there. The arms and thighs are probably a slightly different patient population. They're more in the, what Kim just referred to as the massive weight loss patients, which there's no definition for, but for the sake of argument, more than, say, 30 kilos, they tend to just get, their skin's been stretched more, so they have more areas where there's loose skin. So we see a lot of those patients as well.
I think it's good that because we do breast and body and arms and legs, that so for those significant or massive weight loss patients, even if their sole focus at the start is on their tummy or on their breast, and they may say, look, I'm planning on doing other things down the track, it's a really good opportunity at their first consultation to actually assess all the areas and come up with a short, medium, long-term plan. And it's not us talking people into surgeries that they don't need, but it's more just so useful with planning, because if your priority right now is your breast, but you're thinking you might want your thighs and your arms and your tummy at some point in time, instead of coming once a year for 4 years and having 4 different operations, that it may be a much better approach and much less downtime to combine 2 of those procedures so that the patient's only having 2 operations, 2 lots of downtime versus 4 if they've not got an overall plan.
And a more holistic view as well. Like you're not chopping and changing between a bunch of different surgeons as well.
Correct.
Yeah, I just had a great example. I just saw the patient just before, and she's now 6 weeks post-op, but she came to see me for a thigh reduction. And when I assessed her, I felt the issue really was that her lower body had sagged. And so rather than operate on her thighs, I felt she would get a better result, improvement to her thighs from a body lift, plus it would improve her lower back and buttock area, plus her tummy. And I just saw her then, and absolutely the right decision. She's had a significant improvement and to her thighs. And even if down the track she still needs a procedure on thighs, it's going to be a much smaller procedure and we can get a much better result. That's just one example, but seeing a surgeon who does all of these things that are complementary, I think means that you get, as Kim was saying before, if you don't do body lifts and you just do tummy tucks, well, you're always just going to recommend a tummy tuck. So if all you have is a hammer, then all the world's a nail. But we would assess someone more from a 360-degree point of view from their lower body compared to someone who's just doing a tummy tuck. And we certainly see a fair number of patients who've had a tummy tuck elsewhere, and then that flank area, the love handle area, is then relatively more prominent because the tummy is flatter. So in some ways they've exacerbated, not by making it worse, but by making the other area better, they've exacerbated another problem which probably could have been addressed in one operation.
And not just the lower body, the upper body that we assess, like 360 as well, because it would not be uncommon in that cohort of patients to do a breast reduction or a breast lift that then also goes all the way around the back as well.
How important do you think it is to specialise or be hyper niche in what you're doing?
Yeah, Malcolm Gladwell, 10,000 hours. And it's 10,000 practiced hours. So you can't just do 10,000 hours of skin cancers and then be able to do a tummy tuck. Like if you've done 10,000 hours of doing tummy tucks and breast reductions and all of those surgeries, then I think you do get better. And if you've just got a very broad practice and you're doing a bit of skin cancer and doing a bit of hand surgery and doing a little bit of breast and road trauma and all those sorts of things, it's pretty hard to become an expert in any of them. Like, you'll be competent in all of them, but we pick things up, and we've talked about it before, our audits, and where we can be hypercritical of the work we do, and it's about the 1%ers and trying to improve the results even more. But if you're doing 10 tummy tucks in a year, it's pretty hard to make an assessment of what you could do better because you just don't have a sample size.
Also, last question. If you guys weren't working in breast, body, face niche, what would you be doing in terms like surgery niche-wise? Not like a basketball player.
Hand surgery.
Does it have to be limited to plastic surgery?
I would prefer it, but you can say outside that. Look, I'll give you 2 answers.
Okay. If I had to choose another surgical specialty, well, along the lines of plastic surgery, I'd maybe focus more on maxillofacial. The results are pretty amazing. If it was a specialty out of plastic surgery, I'd probably go orthopedics just because it's
All you need is a hammer then.
Well,
the whole world's know.
But it's just the way things fall. Hospitals just really love having orthopedic surgeons in, so it just makes it much, much easier getting operating time and things like that.
And they don't have to look after the patient. They just
they generally
fix the bony
just
bit and other people outsource all the rest of it.
Did you want to have 2 answers, Stu?
No, I'm good.
Okay. Why would you do
Well, I could
hands?
be an orthopaedic hand surgeon. So I've done a fellowship in hand surgery, paediatric hand surgery. So it's an area I'm very familiar with. I've done a lot of hand surgery. The function is the cool part of that, I think. You can assess a hand and whether it's an acute injury or something chronic. Acute injuries a bit more obviously. Someone's stuck their knife through their hand and you can examine them. You can say, well, this tendon and that nerve have been injured. You can surgically fix them. The anatomy of the hand is, I think, still one of the most interesting things. It's pretty cool. And the amount of things that the hands can do and how flexible they are. You can fix those things up, and with a compliant patient that does their therapy well, you can return them completely back to normal. One other thing on that was doing the paediatric hand surgery is pretty amazing as well. That, say, a kid, and it's a pretty uncommon thing, but I've been involved in 2 cases where a child was born with no thumb whatsoever. Their index finger, their brain already starts turning their index finger into their thumb, and so they'll, even when they're little, they start using that as their grasping area. And then the surgery is unbelievably cool to then shorten that index finger, reattach the bones and shorten the tendons. So their brain's already turned it into a thumb, and then you surgically turn it into a thumb.
Does it stay when you're moving it? Does it move to a traditional thumb position?
Yeah, so it looks like a thumb, but they're just, and you're like, what's wrong with it? And it takes, as an observer, a little bit to be like, oh, they've just got 3 fingers, not 4. And their function is normal, essentially, once they've healed from that. Cool. It's really cool.
Fun fact about that operation, first operation I ever saw. That's not even the weird part. I saw
You've
it.
had one yourself.
No, 5 fingers. I saw it when I was doing work experience at school. Like, wasn't done at school, it was done at the hospital. But I was doing work experience with a plastic surgeon, and I was 16. But I clearly remember seeing that procedure, which is called a polycisation.
That's so rare. Like,
what are the chances?
Yeah, that's it.
It's a weird first operation to say.
It's a cool thing to get you over the line, though. It's like, look how clever these people are.
I know.
If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.